Alrighty, Jenny, would you do a roll call, please?
Supervisor Angus?
Here.
Supervisor Johnson?
Present.
Supervisor Gould? Supervisor Gould? Supervisor Watson?
Present, thank you.
And we have Chairman Bishop, so we have a quorum and you're good to go.
Okay, thank you very much. The Board of Supervisors may, by motion, recess into executive session to receive legal advice from the board's attorney on any item contained in the agenda pursuant to ARS 38431.03. And I see Mr. Esplin is in the audience this morning. So before we start the meeting, the last meeting, I had difficulty hearing whether or not the speaker was Supervisor Johnson or Supervisor Gould. So if I could please just get you to indulge me, and if you speak and you're on the telephone, please just give your name first, and then I won't be embarrassed by who I'm calling. So the first item we have on the agenda is discussion of possible action. First and only item is possible action regarding an update from the Public Health Director to the Board of Supervisors regarding recent issues, actions, events, and county responses regarding COVID, and taking any necessary actions upon those updates. So, Denise Burley?
Madam Chair, members of the board, thank you. Just wanted to provide a few updates here. Hospital capacity again, we continue to monitor that on a daily basis, and for the most part, we do not have any capacity issues, so hospitals are adequately prepared for any kind of a surge that we may have in cases or a need for hospitalization from these cases. Were there any questions about that report?
Any questions?
Okay.
Madam Chair, Supervisor Johnson, District 3, Lake Havasu.
Thank you, Supervisor Johnson. Go ahead.
Ms. Burley, I'm worried about Lake Havasu and the lack of bed space they have. Do we have an explanation for that?
You know, we do not, actually, and I have a plan to call the hospital today to try to learn a little bit more about what the situation is at Havasu Regional Medical Center. I will try to provide a report back once I learn that.
Thank you. That's all I have, Madam Chair. Supervisor Johnson, District 3, Lake Havasu.
Thank you. You are awesome. All right. Any other questions? All right.
All right. So,
Madam Chair,
oh, yes.
Supervisor Angus?
can you hear me without an echo?
No, you do have a bit of an echo.
Ron Gould
has joined the conference.
Okay, this should be better. Is this better?
Yes. That does sound better, yes.
Okay. Denise, so today I read in the paper that a doctor in Bullhead is starting a study with antibodies, and I wanted to know if that is approved through the county, how that happens. I mean, what are the parameters of the study? Is that something that Bullhead City has been chosen? Can you just give us a little insight into that?
I can, yes, absolutely, Supervisor Angus. So I did speak with Dr. Zeri about what his intentions were, and his intent for this study is to understand whether or not the antibody test that he has purchased, he had purchased 20 of these, was reliable. Now, granted, I believe last I understood he had purchased 20 of these tests. Testing 20 does not necessarily lead one to believe that that's a reliable test result. So at this point, we do not, it's not something that we can continue to endorse as far as the use of an antibody test to diagnose either positivity or immunity from COVID-19.
Is this test, this test is not approved from the Arizona Department of Health?
Correct, yes. The Arizona Department of Health Services also does not endorse any testing or recommend any antibody testing yet because the test results are not reliable enough.
Okay, and I understand that Lake Havasu is doing the same test, like I guess they're working together. So has there been anything submitted about the parameters of the study and what they hope to? And just out of curiosity, if you're giving a test that is not approved by anybody and we haven't sanctioned it, are they allowed to charge for it?
You know, I'm not familiar with the charging piece of it, Supervisor Angus, and whether or not they can charge. My understanding, again, from Dr. Zeri was that he was not charging for these antibody tests, and it was more just a study to understand whether or not the test that he chose was a reliable test, or at least could sort of indicate that.
How would you know it was reliable? How would you know it was reliable if there's no standards? Like, what are you comparing it to?
Well, and I think you bring up some very good points about how you research and study a product. And I have had very limited conversation with Dr. Zeri, so I'm not sure if there are other parameters that he has put in place for his research study, and he would be definitely a person that can more accurately speak to that.
Thank you very much.
Mm-hmm.
Okay, any other questions?
Okay.
All right, Denise?
All right, we'll continue.
Thank you.
Testing numbers in our webpage. We continue to struggle with having discrepancies between what is reported to us by the hospitals and North Country and what ADHS has on their website. And their website draws from a different source. And we would like to try to connect those two. We know we can't do that through a link, which is how other counties have linked their website numbers to their county numbers. And we all know the limitations of that as far as case counts, that theirs is only updated at 9 o'clock in the morning, and those results are really from up to 5 o'clock the previous day. So we're not advocating for that at this point, but what we are looking at is whether or not we should be using ADHS numbers for testing numbers so that those numbers do match, because our information will always have missing pieces because we don't get that private provider testing number in our, they don't send that number to us. Additionally, North Country sends their numbers to us once a week, whereas the other hospitals, the 4 main hospitals, send us that information daily. So we're always kind of behind in that, and I would prefer that we have an accurate reflection of those, and I just want to make that recommendation to the board that we use ADHS numbers for that purpose. And then we'll continue to do real-time updates on our case counts.
Okay, I would not have a problem with that. Is there any other comments, discussions? There being none, go ahead.
Okay, all right. We will make that change then. Thank you. All right, so there's been some question about the source of cases. I know when we send reports as far as the press release and information to the board, we indicate whether or not, or at least try where we can to indicate if it's travel-related, epi-linked, or community acquired, were the 3 different definitions that we were using. I did ask staff to provide maybe a little bit more information and a little deeper dive into that, and I thought I would share that with you. If there are specific questions, I will likely bring up Lynn Valentine to help me respond to those, as she has a lot more experience around these particular cases and can probably be a little bit more articulate in her responses. So, all right. So what we have, let me find my information. We have information on 68 of the 69 cases, so that you're aware of that. And it is true and an accurate statement when we list on there that we don't know what the source is often until the investigation proceeds and we get more information from that particular case. So once we do, then we can report it out in aggregate form, but until that point, oftentimes we're not familiar with the circumstances and we need more information to make that determination. So what we have as of right now are 9 travel-related or imported cases of infection. These are acquired outside of Mojave County and brought into our county. And ours are generally from either neighboring states, even other states, and/or international travel still. So, okay, or at least going back to the fact that that would include case 1, 2, 3, and 4, and so on, when travel was really a major factor in bringing the cases to our county. We have 10 that are close contacts to lab-confirmed cases, mostly household contacts. We have 35, and this is a deeper dive than what you've seen so far, so I want to indicate that. You know, in the past, we've just done travel, epi, community, so we're going to add a different category in here for you to give you a little deeper piece of information. But 35 of these are healthcare-associated infections. And let me define what that means. That's acquired during hospitalization or stays in long-term care facilities or acquired by healthcare workers with or without known contact to a lab-confirmed case. Okay? And then we have 14 that are community-acquired. So, and again, we have one case that has not been fully investigated, so I don't have an answer for you. Any questions?
Madam Chair?
Supervisor Angus.
So the first number was 9 that you said brought into the county from other places.
Correct?
Is that how I interpret that?
Correct. Yes, those are your travel related.
The second one, travel related. Okay, the second one I'm a little bit more confused about. So can you repeat that, please?
Sure. Those are, I listed the number 10, and those are close contacts to lab-confirmed cases. So those are mostly your household contacts to those lab-confirmed cases.
Got it. Thanks.
Certainly.
Anyone else?
Madam Chair, Supervisor Johnson.
Go ahead, Supervisor Johnson.
Thank you. To follow up on Supervisor Angus's travel, is it possible that we could list travel to California, travel to Utah, international travel? Because I'm guessing we don't have any travel that's related to Kingman to Havasu or Havasu to Parker, just to let our people know that they're not getting it from those locations?
Well, I think in terms of when we look at it as travel related, those are all outside from neighboring states, other states, and international anyway. So in defining what a travel-related case is, it wouldn't be from a different county. It would be from a different state or international travel.
Okay. Community, when you speak of community, does that mean they're out and about in the community?
If you're referring to the ones that are community acquired, what that means is that they don't have any association with travel, they don't have any association with healthcare, and they have no close household contact with somebody that's a lab-confirmed case. So whether or not it's a household contact, a work contact, or a social contact, they don't have that kind of context. So it's an unknown source, basically.
All right. Thank you, Madam Chair.
Okay. Anyone else? Supervisor Watson?
Thank you, Chairman. Denise, I was going over the statistics again last night. Kingman by far has the largest number of cases, but it's also the facilities that are doing the most testing.
Correct.
Do you anticipate that there are similar large numbers in Lake Havasu City and Bullhead City because of their lack of intensive testing?
You know, anecdotally, I would say that there's probably more of the virus out there, more of the disease out there than we're aware of, because there's not the same level of testing going on in those communities. And I think that's really the impetus and the real drive to increase our testing, is so that we will have a better sense of what that virus really looks like and spread in our community.
Thank you, and that's kind of the direction that I wanted to go. If we were doing more testing, then we could get an accurate estimation of when it's going to peak and level and decline. Until that time, we're kind of shooting in the dark here.
That would be correct.
So what will we do to influence those other agencies to do more testing?
Well, I think the influence is still the fact that there's a lack of testing supplies available. And I can't speak to why Kingman Regional had more supplies than another hospital at this point. I don't know the answer to that question. But I do think there continues to be, through our phone calls with local health officers and ADHS, there continues to be a shortage of testing supplies available to increase that testing. And that is a major emphasis for the state and the federal government, is to increase that testing, which means we need those supplies in order to do that work.
Just seems incredible that Kingman Regional Medical Center would have more supplies available than the other facilities.
I absolutely understand, and I honestly don't have an answer as to the why for that.
What if you could inquire as to
I can.
that? Thank you.
Sure.
So Denise, would that have anything
Madam
to
Chair?
do with the fact that Kingman has 2 hospitals? I mean, does each hospital get a certain amount of testing equipment?
They generally get the, I don't know, can you speak more to their testing supplies? Okay. Yeah, I think we need to inquire with each of the hospitals, but, you know, they have their own sources for those supplies outside of the health department, and they have a different supply chain. So I imagine each hospital working through their procurement departments are looking for those sources out there. So that's a good question as to the why.
Okay. Supervisor Angus, are you trying to chime in?
Yes, thank you. So it was my understanding that early on, which was only, 5 or 6 weeks ago, that Kingman Regional, since they were part of the Mayo Clinic, they had access to another supply chain. And that's one of the reasons that they did so much more testing than the other areas. That's number one. Number two is, just found out today that there is going to be a drive-in testing facility out in Fort Mojave. It's being done by a couple of doctors, and so they're able to get tests. I've never quite understand what the inability to get tests was when there appears to be a lot of tests on the East Coast. So do you have any insight into that, and did you know about this drive-in testing facility?
Sure. I'm not familiar with the drive-through testing that's going to be occurring in Fort Mojave. As far as testing supplies, I think what you see is that there's a greater demand for testing, such as some of the bigger cities that are having larger outbreaks. Those supplies generally are, they're directed that way, I think, in order to give them the information that they need to make decisions and to try to reduce their outbreak. And beyond that, I think that there's still a lot of room for improvement around the supply chain there. And originally, it was the media that was used for collecting the swabs. And I think we're still working on that issue, although I do think it's improving. We're still not to that point where we have all of the, we have this kind of free chain and supply chain of product for that.
Madam Chair, Supervisor Johnson.
Yes, go ahead, Supervisor Johnson.
Is it possible that when you make your call, Ms. Denise, that to the hospitals, that you ask them how many tests they have on hand? Because it would be interesting to know if they have, like say Havas, who has 1,000 on hand, but we're just rationing them out. I think that would be helpful, and that might answer part of Supervisor Watson's question too.
I will certainly inquire with them when I do call them. Thank you.
Okay. Anyone
Madam
else?
Chair, I'm sorry, tonight.
Supervisor Angus, are you wanting to speak?
Yes, I'm sorry. I should have put this before. So one of the things I keep hearing out in the community is, are we still using the same criteria from the beginning? Because it seems like a very high level, and I think that in the beginning when we didn't have that many tests, that seems to be the reason given. But now that we have relaxed it a bit, is there any movement from CDC or Arizona or ADH to lower? So I think, what is it right now? Do you have to have 3 out of 4 of the symptoms? Do you still have to show that you traveled? Has it changed at all since the beginning?
Yes, actually, the testing matrix has changed dramatically. In some cases, it would change twice in a week as we learned more and as more testing kits became available, as we kind of move forward with decision making. So do you have the testing matrix by chance? Lynn's actually here, and she can actually speak to the testing matrix.
Just as Denise said, it has changed quite a bit, but also the recommendation is for to prioritize individuals who work in certain, who meet certain criteria as far as maybe the industry that they work in, hospitalized patients and healthcare facility workers with symptoms, they're prioritized. Then it comes to residents who are in long-term care facilities, individuals who are over the age of 65 with symptoms. So there's criteria that way as well, or a prioritization of those who are going to be tested. But most of the facilities are following the testing matrix, and it has changed from the very beginning. And right now it's there's 3 different criteria, or 3 different tiers. The top one being fever or signs of symptoms with lower respiratory illness not requiring hospitalization. And it kind of goes from there. So I don't want to sit here and read the whole thing to you, but we definitely can, send a copy of the testing matrix so that you can see it, and maybe that'll shed a little more light on who's being tested and what the criteria is.
I would appreciate that. Thank you.
Okay.
Okay, any other questions for Ms. Valentine? Okay, thank you.
Let me make a note here. Okay. The other item that I had is I submitted that draft plan as far as reopening, and I don't know if you'd like to, if you had any questions on that plan. It's a very general plan, so when you look at some of the criteria that are listed, let me pull that up real quick. And it's not necessarily in a public-friendly view at the moment. If you move forward with adopting plans, we'll try to put it into a more friendly view so that people will be able to kind of look at it very easily and determine where we are in this process. But it's based primarily on the White House plan, as you'll notice in that first section there. And then also in the left-hand column, as you go down, you'll see that those are all the criteria that must be met in each of the phases. And then on the right is the Mojave County piece to that, which is really in large part lock and step with that plan. I think the main considerations moving forward really are, do we have enough testing available in our community to really make decisions? That's a big question. And the other part is, when we move forward, I know in the president's plan, there was one point, or the White House plan, it said monitor conditions and immediately take steps to limit and mitigate any rebounds or outbreaks by restarting a phase or returning to an earlier phase. And I recognize the challenges around businesses being closed and kind of this stay-at-home measure that we're taking right now. But I also recognize difficulty as well in stepping back, moving forward and then having to step back. So just kind of keeping that as a point of reference moving forward.
Denise, I have a question. Where do we need to be in order to feel comfortable that we have enough testing going on so that we can make educated decisions based on the data?
Well, I think in this, I believe there's a place here. Let me find that real quick, if you don't mind.
Yeah, it just seems if we don't have the testing, we don't have the data, and we're kind of doing guesstimates rather than...
Right. So in order to move through the phases, we need to be seeing a decline in the number of cases, which we have not quite seen. I know Mike, the county manager, pointed out actually that we did have a spike. I think it was the week of March 23rd. But one thing to keep in mind about that particular spike is prior to that, there was testing going on and we hadn't received the results. There were delays in the results. So suddenly, here comes this wave of results into our lap, and we address each case, but it shows this spike as a result of the, getting those results back and getting positive results, part of that. The other part is rapid diagnostic testing capacity to sufficiently test at minimum all people with symptoms, as well as close contacts and those in essential roles. So you can kind of see where we are today and where we need to be on the testing piece. Healthcare system is able to safely care for all patients, including having appropriate PPE. We still continue to see some shortages in PPE. Again, like testing supplies, I think that chain is opening up a bit, but I do think we're still seeing shortages out in the community. And then our capacity internally to do contact tracing on all new cases and their close contacts. And that is something actually that ADHS is working with local health departments on right now, is contact tracing processes and and systems and software that may help us do that. And they're doing a lot of the research on their end, and they'll be reporting back to us in our biweekly meetings so that we can get an update on progress towards that.
Hey, Denise, with the graph that you have now showing that peak, which is as you pointed out, not really valid, can we do another graph similar to that, but using the date of the testing? Would that show a more valid more of a valid indicator as to where we are and how we've grown or declined?
Right.
Do you have that information on the dates?
I don't know that we have it readily available, so let me look and see what we can do.
Yeah, it would be interesting to see that.
Okay. And if I'll see if that's possible. Okay.
Any discussion, questions for Denise? Mr. Hendricks.
Thank you, Madam Chairman. And this is a question on the charts and on the graphs that I was curious about, and I really don't have an answer to, and I'm not sure anybody would have an answer to, and I'm sure we don't have enough of a testing sample to statistically be able to tell where we are currently, but it's if you could help me with this, I would appreciate it. That the measures. It's my understanding that the measures that we've taken and the efforts that the health department and our communities have taken have actually changed the an actual graph of people who get infected or people who could conceivably be deceased to flatten the peak and spread out the peak so that the occurrences aren't happening so quickly. And the reason that we did that was so that we wouldn't overrun our health facilities and our health capacities to be able to assist and treat and help people get better and direct them into what they needed to do to improve and to allow those people not to impact other people. So the goal was to, and correct me if I'm wrong, was to flatten that graph so that it wouldn't have such a drastic peak, let's say like what New York has experienced. And it would look more like some of the other larger cities that have been successful. So, but the question I would have is, obviously, the area under the curve is the number of people that will contract the disease and be impacted. And barring any lack of medical facility, is that area under the curve going to be relatively the same, even though the peak would be different, would be relatively the same number but extended over a longer period of time?
Correct. That would be the spreading of the curve.
So whoever's basically those people that are going to have the would be, could catch the disease will catch the disease.
I think there's two points, right. I think the point is that we don't want to see such a large increase in our caseload, especially those that need to be hospitalized, that spike pushes us beyond our hospital capacity. So that's the one piece. I think the other is that we spread it out so that we also maybe have opportunity messaging-wise and action and measures-wise where we can actually reduce the number of cases. So it's twofold there for us.
Thank you, Denise. Thanks.
Okay. Anyone else?
I have a couple of questions, Madam Chair, if Denise is through.
Yes, go ahead.
Why aren't we reporting the numbers from the reservation?
Those are actually counted in our service area counts. And because the number of individuals is so small, that there's a very good chance that we would identify that individual in that community if we reported it out separately.
I see that the Wallapai tribe is reporting out 7 in their area. I was just curious why we were reporting the nation.
And I think...
Well, go ahead.
Even with the ADHS website, they were working on agreements with the tribes to be able to use that data to report out, and to my knowledge, they have not reached those agreements with the tribes.
All right, thank you. I do understand, like we all do, that test kits are in short supply. But have we or should we be testing our long-term care facilities?
Yes. Yes, I think that that's going to be a high priority, both for long-term care facilities themselves as well as public health in the very near future.
All right. I guess the other question I would have would be, can you kind of, if there's a short explanation, tell us the difference between the COVID virus and the flu?
Okay, hang on.
Good luck on that one.
Just give me 1 second, if you wouldn't mind. I do have notes for that. I have to find them, but I have them. Shoot. Sorry, taking me a little longer than I thought. You know what? Get it on the printer. Do you have that available, Lynn? Thanks. So, to be clear, they are 2 different viruses. And so they, thanks. Excuse me just 1 second while I look it up. Have that available and I did reach out to our epidemiologist, Supervisor Johnson, on those questions and got a response. So I'm just looking for those answers so I can more accurately share that information with you. Did you find it? You know, sometimes technology fails you miserably. Oh, good, thank you. Thanks. Okay. So first off, they are 2 different types of viruses. It's important to note that COVID-19 is mainly transmitted through droplets, as we've talked about before, and is not an airborne virus. So that is important to recognize. Let's see here. So it means you can be infected by breathing in the virus if you are within 1 meter of a person who has COVID-19, or by touching contaminated surfaces and then touching your eyes, nose, or mouth before washing your hands. So the see. So COVID-19 is spreading very easily and sustainably between people. And it's, at this point, the evidence is pointing that it's actually spreading faster or more easily than the influenza, than flu. So let's see here. The incubation period for COVID-19 is 2 to 14 days. Incubation period for flu is 1 to 4 days, so significantly different, and people could be walking around asymptomatic for some time before it's actually tested. Let's see. Supervisor Johnson, do you have any specific questions more to the point that you would like answered about the difference between flu and COVID-19?
We all get questions on why why the president and our governors are reacting the way they are. So I guess I was asking the differences that would make it an emergency for us to lock down businesses and everything. Would it have anything to do with the fact that we don't have shots available, which sometimes don't work for the virus that's coming around that year, but supposedly they make it less offensive to us, so we have milder symptoms if we do get the shot, where there's no shot for this or any kind of basic way to stop it or treat it.
Certainly. Well, I think, when this disease first came out, you noticed the word novel. So it's new, meaning your body has never seen this before. Your body has seen many flus before. And so in one sense or another, your body's probably generated and built up some immunity to some of the flus that are out there. And in this case, your body has not seen this disease before, and so does not have the immunity at all built up in the system to address it. Did you have anything you wanted to add?
And just
Okay, I guess my last question would be then, we had talked about how long the virus would last in the air and surfaces. Were you able to get any answers on that? And if not, I guess you can just mail them to them.
This is Lynn, and it is not an airborne disease. It's not floating in the air. It's spread through respiratory droplets of an infected person. So there are some truly airborne diseases such as tuberculosis and measles where the particles are floating in the air for a period of time. But with COVID, that's not the case. It is thought to be spread through the respiratory droplets of an infected individual.
So what you're saying is there's no need for us to be wearing masks, and the information we're getting that it could last up to 2 hours are wrong?
Well, no, the masks help to protect us from, well, first of all, like an individual who may be infected and doesn't know. It helps protect others from their respiratory droplets that might be infected with the virus. As far as them being suspended in the air, that's not the case. They're not suspended in the air, just floating around. So the masks do offer some protection, but it's from the respiratory droplets of others. And then if they cough or sneeze, that's going to add some level of protection as well to the individual who's wearing the mask.
So to follow up on that, if I'm at the grocery store and somebody at the end of the aisle sneezes, I don't have to worry.
Well, the general rule is if you're about 6 feet away, then that's a good distance to be. And then if you have a mask on, that's going to help to add an extra layer of protection.
Now, I realize we can't trust the Chinese, but I saw a diagram where they talked about a restaurant where they had the 6-foot spacing, and supposedly they had people at both tables that got the virus from the one table, so that would probably just be a fallacy.
I don't know that specific case. I couldn't speak directly to that, you know, and what other factors may have come into play. So I'm not sure on that.
Okay, Madam Chair, I'll let somebody else jump in.
Okay, thank you. Is there anybody else that wants to speak?
Madam Chairman.
Supervisor Gold?
Thank you, Madam Chairman. I was watching a Mythbusters where they tested that people could sneeze 18 feet before it hit the ground. So 6 foot might be a little short.
I think it might be a little difficult to ask people to stay more than 6 feet at this point. Yes, I mean, I think these are all generalizations when we talk about them, as far as those distances and precautions people can take, and that's really what we're able to do at this point.
Sure. It just, I think wearing a mask gives you a little margin for error.
Mm-hmm. That is true. It gives you an extra layer, doesn't it?
It does. Thank you.
Anyone else? Hearing none. Do you have anything else for us, Denise?
Not at this time.
Okay. Ryan Esplin, I see that he's moving toward the podium.
Chairman and members of the board, at the last board meeting, there was a discussion about the restrooms at the public parks.
Yes.
And I was asked to contact the governor's attorney to get some clarification from that. She reached out to me and we spoke, and Supervisor Angus asked that I report that back to the board, if I may do that.
Okay, yeah, go ahead.
So the question was the closure of the restrooms at the parks, and that was the limited question that I was asking. And I reached out to a person. I don't know if it's the governor's own attorney or whatnot. I don't know the connection, but it sounds like she represents the governor or some kind of connection to the governor in some way. And the response back was that, and just a little bit of background. The governor first issued an order closing certain businesses. That was the bars, the gyms, and the in-dining restaurants. Then a couple days later, the governor then issued an order saying that essential services need to remain open, and then identified a number of essential services. Then after that, then the governor made some clarifications as to what is essential, what is not, and that's where the governor said there, the closure of the restrooms and so forth. And so that's what we were talking about, and that's when I talked to the attorney, and she explained that the governor's intention was that that would, whether to close or open a restroom at a public park would be up to the local jurisdictions. The local governments would make that decision. That was what the governor had intended. So that was the report back that I'm giving to the board, and I told Supervisor Angus that I would do that, so that you have that. You should not rely on this as hard legal advice and things. I'm just reporting back to you the information that I got from her. So if you have any questions, I can answer that as well.
Okay, and just from experience, I know the community parks in the outlying areas, the remote communities, have always been closed unless there was a large gathering at the park, and then the bathrooms would be open at that point. And that was due over the years because of vandalism and destruction of the bathrooms. So I don't think that has changed any with our community parks.
Madam Chair?
Supervisor Angus.
Well, this is more for the parks, the cities, for clarification. The person that I gave the name to Ryan was given to me by Ben Blank, who is the spokesman for the governor, and from Craig Sullivan from CSA. So this was the person. So now we have it in writing. The concern was the only thing we had in writing was the order from the governor. So the concern in the cities was, well, if we open up based on what we hear, what somebody whispers to us, then there's a chance that it can come back to haunt us later, liability, whatnot. So what I asked of Ryan was to get it in writing, which is exactly what he did. So I think this is hard legal. I have to disagree with you, Ryan. I think this is hard legal justification if cities or even if something that we wanted to do to open up the public restrooms.
No, I want to make sure that I'm clear, Supervisor Angus, if I could answer that, is that, no, we are getting clarification from the governor on this specific issue. Yes, I absolutely agree with you. And so on this very small legal issue of, the opening or closing of the restrooms during the pandemic, what the governor has instructed, and I agree with you, this is coming at least from, sounds like the representative of the governor, is that it's up to the local jurisdictions to make that call. So the county, the cities, and so forth, they would make that call. Absolutely, that's what I'm talking about. When I'm talking about, please don't rely on this, I don't want the public and other people to run off with this and go forward with this and kind of extrapolate from that. That's what I'm trying to say is, look, what I did was I contacted this person who represents the governor. We received the interpretation from the governor for us on this specific legal issue. It's really, I'm just trying to guard against the public reading more into this than is necessary.
Okay, so from what I'm understanding, Ryan, is it's up to the county to make that decision for county parks. It's up to the city to make that decision for city parks.
Yes, and that's what she's answered. And yes, and that's I agree with you, Supervisor Angus. That yes, that's we have in writing confirmed that that's the interpretation of that. So yes, that's what we have. I'm always hesitant to say, here, well, this is the legal advice we got, and then somebody else runs off with it. So that's why this was for you, the client. We advised, and this we got the information we got, and we're conveying that to you.
Okay, thank you. Any other questions, Supervisor Angus?
No, thanks.
Okay. Any further discussion on any topic before we adjourn? All right, we are adjourned.